Welcome to the Deep Dive. Today, we're tackling a really specific and maybe less familiar medical condition, mesenteric venous thrombosis, MVT for short.
Exactly. And we've been digging into a key chapter from Rutherford's Vascular Surgery and Endovascular Therapy, the latest 10th edition, to really get to grips with it.
Okay, so MVT, you said it's a blood clot. Where exactly?
Right. It's a clot forming in the superior mesenteric vein. That's the main vein draining your small intestine. And sometimes, it can spread into the portal vein heading to the liver or the splenic vein.
Got it. And it took a while for doctors to see this as separate from, like, artery blockages in the same area, didn't it?
It did, yeah. Rutherford's mentions Elliot reporting a successful treatment way back in 1895, but it was really Warren and Eberhard in 1935 who established MVT as its own thing, distinct from arterial problems.
So our mission for this deep dive is to really unpack MVT. Who gets it? Why does it happen? How do we spot it? And crucially, how is it treated now? We're aiming to pull out the essentials for you.
Sounds good. And maybe the best place to start is, well, who typically develops this condition?
The chapter points towards middle-aged and older adults, mainly. And there was that interesting study from Malmo in Sweden.
Ah, yes, the Malmo data. They compared incidence rates across two different periods, 1970, 1982, and then 2000, 2006.
Right. What did they find?
Well, initially, the rate for MVT leading to what are called transmural intestinal infarction, where the whole bowel wall is affected, was about 1.8 per 100,000 person years.
Okay.
But in the later period, that jumped up to 2.7.
An increase. But maybe not because it was actually happening more often.
Exactly. That's the fascinating part. The researchers suggest it was more about how it was being found. Autopsy rates, which were really high in the first period, like 87%, absolutely plummeted later on, down to just 10%.
Wow. Okay. So fewer postmortem diagnoses.
Right. And at the same time, diagnostic imaging, especially CT scans, just got way better and much more common.
So you're catching more cases in living patients with CTs.
Precisely. In that later Malmo period, CT was the main diagnostic tool for most MVT cases, a total shift.
Makes sense. A change in detection methods really reshaped the numbers we see. What about gender? Any difference there?
It seems so. Pooling data from several studies suggests a bit of a male predominance. The estimate for the female proportion was around 34.5%.
So slightly more common in men.
Okay.
Middle-aged, older adults, slight male lean, and diagnosis now heavily reliant on imaging. Let's get into the why, the pathogenesis.
Yeah, this is key. We usually split MVT into primary and secondary types. Primary is when it just happens. Spontaneous, idiopathic, no clear cause.
But that's rare.
Very rare. About 90% of cases are secondary, meaning they're linked to some other underlying condition or risk factor.
And Rutherford groups these risk factors pretty neatly, right?
It does, basically into three buckets: direct injury to the area, local venous congestion or stasis, slow blood flow, and then thrombophilia, which is just a general increased tendency to form clots.
Okay, let's take direct injury first. That sounds like, well, physical damage.
Yep. Things like abdominal trauma, blunt or penetrating. Also, abdominal surgery is a big one, especially splenectomy, removing the spleen.
Why splenectomy specifically?
The thinking is that when they tie off the splenic vein during the op, a clot can sometimes form there and then sort of creep downwards into the mesenteric system. Propagation, they call it.
Interesting. What else counts as direct injury or local issues?
Intra-abdominal inflammation is another big category. Think pancreatitis or inflammatory bowel disease, IBD, like Crohn's or ulcerative colitis.
Ah, IBD. Is there a strong link
They're
there?
surprisingly strong. The chapter mentions incidental MVT being found in up to 27% of IBD patients in some studies, often in smaller veins near the inflamed bowel, and it seems linked to how severe the IBD is.
Wow.
Yeah. And severe acute pancreatitis is linked more often to clots in the splenic vein because it's right next door, but it can definitely cause MVT too. Also, things like peritonitis, infection in the abdomen or abscesses.
Okay, so trauma, surgery, inflammation. Got it. What about the second category, local venous congestion or stasis, slow flow?
Right. Anything that raises pressure in the portal vein system can cause blood to back up and slow down in the mesenteric veins. The classic example is portal hypertension, usually from liver cirrhosis.
Like a traffic jam in the main vein backing up into the side streets.
Exactly that. Congestive heart failure can do something similar. Other factors include hypersplenism, an overactive spleen, and obesity. There was a case control study linking obesity.
And increased abdominal pressure itself.
Yes, anything that squashes things inside, like abdominal compartment syndrome, could potentially compress the veins and slow flow.
Okay, that leaves the third category, thrombophilia. the tendency to clot easily.
And this is a really significant one. It covers both inherited conditions you're born with and acquired ones that develop later.
Let's start with inherited. What are the big ones?
Well, the chapter notes a pretty high prevalence in MVT patients, maybe 42% to 55%. We're talking about deficiencies in natural anticoagulants like protein C or S, antithrombin III deficiency. The Factor V Leiden mutation is a major one.
Factor V Leiden? I've heard of that. Is it much more common in MVP patients?
Significantly. That Malmo study, again, they found it in 45% of their MVT patients compared to just 7% in the general population there. A huge difference.
Wow. That really points to genetics playing a big role for some people.
Absolutely. Also mentioned are the prothrombin gene, 20/2010 A allele, and even MTHFR gene mutations.
Okay. And what about acquired thrombophilias, conditions people develop?
There's a whole list. The JAT2 V617F mutation is strongly associated, particularly with what are called myeloproliferative disorders, blood cancers like polycythemia vera or essential thrombocytosis.
And MVT can be the first sign of those.
Sometimes, yes, even before the blood counts look abnormal, which is quite striking.
Yeah.
That JAK2 mutation has a real preference for causing clots in the splenic veins and mesenteric portal hepatic.
That's critical for doctors to know. What else is acquired?
Certain cancers, especially pancreatic and colon cancer, oral contraceptive use is a known risk factor. The myeloproliferative disorders themselves, once diagnosed, heparin-induced thrombocytopenia, antiphospholipid syndrome, even primary CMV infections.
CMV, cytomegalovirus.
Yeah, the virus. And having a history of clots elsewhere, like a DVT in the leg. They even mention a potential link to laparoscopic surgery, maybe due to the increased abdominal pressure causing some venous stasis during the procedure.
So it's a really complex web of potential causes, with these secondary factors being way more common.
Precisely. And figuring out which of these might be at play is crucial for managing the patient long term.
Right. So we know who gets it and why. But what actually happens if MVT occurs and isn't treated? What's the natural history? Seems tricky to pin down.
It is tricky because it's relatively uncommon and sometimes people might have it without obvious symptoms. We don't have a perfect picture.
But the autopsy data gives some clues.
It does. That study finding MVT in 0.1% of autopsies is telling. And in most of those cases, it was linked to that severe transmural infarction and was considered the cause of death. So it can be very serious.
And it's different from just a clot in the portal vein, the PVT you mentioned earlier.
Yeah, quite different in presentation. PVT alone is actually more common in autopsy studies, maybe 10 times more. But those patients were often asymptomatic, and PVT itself was rarely the cause of death.
So the location specifically involving the superior mesenteric vein is what makes MVT potentially so dangerous.
Exactly. Superior MVT is symptomatic in the vast majority of cases, something like 92%. And it leads to bowel gangrene, quite often maybe a third to almost half of cases, depending on how quickly it's caught.
That really underlines the need for prompt diagnosis. Okay, so if it's often symptomatic and risky, what does the damage actually look like, pathologically?
The key is how much of the vein is blocked and how good the collateral circulation is, alternative blood pathways. If the SMV is blocked, like in symptomatic MVT, the risk of intestinal ischemia or lack of blood flow goes way up, much higher than with isolated PVT.
And if a surgeon operates, what do they typically see?
They'll usually find a specific segment of the small bowel, often the jejunum or ileum, that looks swollen, maybe a bit reddish or purplish from the congestion.
But the artery supplying it is okay.
Usually, yes. A key finding is that you can still feel the pulse in the superior mesenteric artery, SMA, and its branches. That helps distinguish it from an arterial blockage.
Right, because arterial blockage would mean no pulse and maybe a different look to the bowel, paler or darker.
Exactly. Arterial ischemia often looks different, maybe more widespread, patchy bluish areas, or even black if it's fully gangrenous. With MVT, when they resect the affected bowel, if they cut the mesenteric veins without tying them first, they'll see the clot inside. But the arteries will spurt blood, showing they were open.
Okay, clear distinction. So how do doctors actually diagnose this in a patient presenting with symptoms?
Well, first they kind of categorize it. Acute MVT is symptoms for less than 4 weeks. Chronic is longer than 4 weeks without infarction, or maybe it's found by chance on a scan done for something else. Most cases tend to be acute.
And what are the typical symptoms of acute MVT?
It often starts quite insidiously. Diffuse, kind of vague abdominal pain is really common, and it might have been going on for days, even weeks. Nausea and vomiting are also very frequent.
Less common thing.
Diarrhea, sometimes lower GI bleeding.
Yeah.
The sort of classic picture described is a middle-aged person, maybe with a history of DVT, who comes in with this ongoing belly pain, vomiting, maybe some abdominal distension, and labs showing inflammation, like a high CRP level.
And if it gets worse?
Then you might start seeing signs of peritonitis, inflammation of the abdominal lining. Initially localized, but if the bowel wall infarcts completely, peristalsis stops, and you get generalized peritonitis.
But those early symptoms sound like they could be many things, making it hard to diagnose just based on that.
Extremely hard. The chapter even notes one study where none of the referrals to radiology initially suspected MVT. It highlights the challenge.
So history and physical exam raise suspicion, but aren't definitive. What about blood tests? Any specific markers?
Unfortunately, no great specific biomarkers for the intestinal ischemia itself. D-dimer, the clot breakdown product, might be elevated, but it's not specific at all. A normal D-dimer might help rule it out, but an elevated one doesn't confirm MVT.
But testing for those underlying clotting disorders, thrombophilia, is important once MVT is diagnosed.
Oh, absolutely. Unless there's a really obvious cause like abdominal cancer, screening for inherited things like Factor V Leiden, protein CS deficiency, and acquired ones like JAK2 mutation or lupus anticoagulant is generally recommended.
And checking blood counts later for those myeloproliferative disorders.
Yes, getting a full blood count with differentiation at follow-up is a good idea, just in case the MVT was the first sign.
Okay, so if clinical signs and basic labs are tricky, imaging must be the key. You mentioned CT scans earlier.
Definitely. Contrast-enhanced CT, specifically timed for the portal venous phase, when the contrast lights up those veins, is the gold standard, the most important diagnostic tool.
And what are they looking for on the scan?
The main thing is seeing the clot itself, the thrombus, within the superior mesenteric vein, and maybe extending into the portal or splenic veins. But they also look for secondary signs in the bowel and surrounding tissues, things like thickening or swelling of the bowel wall, dilated loops of bowel, maybe some fluid or haziness in the mesentery around the vessels, or a Seitz fluid in the abdomen. This can be subtle sometimes.
So the radiologist really needs to look closely at the vessels.
Yes. The chapter emphasizes that radiologists should make a point of examining the mesenteric vessels in anyone presenting with acute or unexplained abdominal pain. CT is very sensitive. One study found it was 100% sensitive for MVT.
Wow. And those secondary bowel signs, they can tell you something about how bad it is.
They can. For instance, seeing significant bowel wall edema might suggest a higher chance that surgery, like a bowel resection, will be needed. It really highlights why the radiologist and the treating physician need to look at these scans together and discuss the findings.
Makes total sense. Okay, so CT confirms the diagnosis. What's the next step? Treatment.
The first-line approach is usually conservative management, basically supportive care.
Meaning?
Things like bowel rest, so nothing by mouth. Maybe a nasogastric tube to decompress the stomach. 4B fluids are crucial for hydration and electrolytes, pain control, obviously. And often TPN, total parenteral nutrition, giving nutrients intravenously while the gut heals.
Antibiotics, too.
Sometimes, yeah. Especially if there's concern about sepsis from bacteria crossing a damaged bowel wall.
And you mentioned surgery might come into play at different times.
Right. 3 main scenarios. Right at admission if the presentation is late and severe, like with peritonitis. Or maybe after a few weeks if the initial conservative treatment with anticoagulation isn't working, the clot is progressing, or the bowel looks worse. And then sometimes months later if a stricture, a narrowing, develops.
What about less invasive options? Endovascular treatments.
Yes, that's an area that's evolved. In specialized centers, they might consider catheter-based approaches. Things like mechanical thrombectomy, basically sucking up the clot, or thrombolysis, dripping clot-busting drugs right onto the thrombus.
Often combined with heparin.
Usually, yes.
Yeah.
The idea is to try and open up the vein more quickly, especially if the patient isn't improving just on heparin anticoagulation alone. It's about early recanalization and trying to save bowel. Needs a multidisciplinary team, though.
Okay, let's focus on the standard medical treatment first. Heparin seems key.
Absolutely. As soon as MVT is diagnosed, the standard is immediate anticoagulation, usually with an intravenous infusion of unfractionated heparin.
Why unfractionated heparin initially?
It acts fast, its effect can be monitored easily with the APTT blood test, and importantly, it can be reversed quickly with protamine if the patient suddenly needs emergency surgery. It might also have some anti-inflammatory effects.
And while they're on heparin, you're watching them very closely.
Very closely. Repeated abdominal exams, checking temperature, monitoring inflammatory markers like CRP and white blood cell count daily. If things aren't improving or they get worse, a repeat CT scan is often done to see what's happening with the clot in the bowel.
Then, once things stabilize and the gut starts working again.
Then you transition to a longer-term anticoagulant. That could be low molecular weight heparin injections, warfarin, a vitamin K antagonist, VKA, or one of the newer direct oral anticoagulants, the DOACs.
How do the DOACs compare?
The chapter suggests they seem to have similar effectiveness and bleeding risk compared to warfarin for MVT, which is encouraging.
And how well does anticoagulation work at dissolving the clot?
Pretty well, actually. Studies show that after about 6 months of anticoagulation, whether it's a DOAC or VKA, the vein has reopened, recanalized in around 70% of patients.
That's quite good.
Right.
How long do people stay on these drugs?
It really depends. The guidelines mentioned from the European Society for Vascular Surgery suggest at least 6 months if there is a clear temporary trigger that's now gone.
But if it was idiopathic or they have an underlying clotting disorder?
Then lifelong anticoagulation is often recommended. The risk of recurrence is significant, and a recurrence can be fatal, so the benefit usually outweighs the bleeding risk in those cases.
Okay, so anticoagulation is the mainstay. Let's revisit those endovascular and surgical options. When do they really come into play?
Endovascular therapies are about actively removing or dissolving the clot. Techniques vary, sometimes through the jugular vein via a tip disc procedure, sometimes directly through the liver into the portal vein, sometimes even via the artery or during open surgery.
The goal is faster clot removal.
Yes, especially for acute clots, maybe less than a week old. Mechanical thrombectomy might work best there. Thrombolysis, the clot-busting drugs, has risks like bleeding, so patient selection is key. Direct delivery to the clot seems more effective than indirect.
But we don't have big trials comparing this head-to-head with just anticoagulation.
Not really large randomized trials, no. It's often considered in centers for patients who seem to be getting worse despite standard heparin therapy. There was a small recent series mentioned using bowel resection followed by balloon thrombectomy in difficult cases with decent results.
And open surgery. When is that unavoidable?
The main triggers are definite peritonitis, severe GI bleeding that can't be controlled, bowel perforation, or a late stricture-causing blockage. If the clinical picture screams peritonitis or deterioration, laparotomy, open surgery is usually needed. Laparoscopy might be used just to look first in experienced hands.
And bowel resection is common in surgery.
Unfortunately, yes. That pooled rate was around 44%. Sometimes open surgical thrombectomy is done too. For really extensive ischemia, the approach might be thrombectomy, reception of clearly dead bowel, heparinization, and then a planned second look surgery a day or two later.
Why the second look?
To reassess the remaining bowel. Sometimes areas that looked questionable initially might recover, so it helps avoid removing more bowel than absolutely necessary.
And connecting the bowel ends?
If it's a short segment removed, they usually reconnect it right away, primary anastomosis. If it's a long segment, they might staple off the ends and plan reconstruction later.
And after surgery, it's back to heparin, bowel rest, TPN, antibiotics.
Yes, all that supportive care until the gut recovers, then transitioning to long-term anticoagulation.
It's definitely a complex decision tree for treatment.
Yeah.
What about the overall outlook, the prognosis for patients with MVT?
It's actually improved quite a bit. The 30-day mortality is now down below 10%, which is significantly better than historical rates.
Likely due to early diagnosis with CT and more non-surgical management.
Almost certainly. Anticoagulation has made a huge difference compared to just observing. The estimated 5-year survival is around 70%.
Though maybe worse if there's underlying cancer.
Yes, prognosis is generally poorer in patients with active malignancy. And complications can still happen, both GI-related like bleeding, late perforation strictures, or short bowel syndrome if a lot was resected, and non-GI problems like pneumonia, infections, kidney issues, sepsis.
Does the extent of the initial clot matter for long-term issues?
It seems so. Less extensive thrombosis might lead to better recovery of the vein on imaging and a lower risk of developing portal hypertension down the line.
Okay, so wrapping this up. Mesenteric venous thrombosis. It's this clot in a crucial intestinal vein. Hits middle-aged to older adults more often and has a whole host of potential triggers. Injury, inflammation, slow flow, underlying clotting tendencies.
Right. And diagnosis hinges heavily on getting that contrast CT scan promptly.
Treatment-wise, the foundation is anticoagulation started immediately, often managing things conservatively. But endovascular techniques and surgery definitely have their place for more severe cases or when things aren't improving.
And it really is complex. Treatment has to be tailored based on the individual's risks, the extent of the clot, how sick they are. It requires careful judgment.
This has been incredibly insightful. It really sheds light on a condition that, while maybe not headline news, carries serious risks if missed.
Indeed. And it makes you think, doesn't it? When you see this huge range of things that can predispose someone, trauma, genetics, IBD, obesity, infections, what does that tell us about thrombotic risk in general? How interconnected are these different factors in contributing to clots, not just in the mesentery, but elsewhere? It really points towards the need for ongoing research into these underlying mechanisms.
That's a really powerful point to ponder. How seemingly unrelated factors might converge to cause such a specific and potentially dangerous event. Thank you for walking us through all that complexity.
My pleasure. It's a fascinating area.
Absolutely. Well, that's all for this deep dive. Until next time.